Good morning, everyone. Welcome to the PG lecture series. We are in our series on nephrology currently, and we are lucky to have Dr. Gopathiraj here with us to teach us about the topic on CKD-U. It's an upcoming emerging entity, and he's here to tell us more about it. Can you please inform others to join as well? Okay. Over to Dr. Gopathiraj.
Am I audible? Thank you, Dr. Sakshi. First of all, I would like to thank Medicine Department for inviting us to this integrated lecture series. Today, I'm going to discuss about the topic CKD-U, which is an emerging entity. So this will be the outline of the topic. First, I'll give introduction and will tell about CKD-U prevalence and hotspots, pathophysiology, risk factors, and case definitions available. Today, I'm going to discuss about Today, I'm going to discuss about the topic CKD-U, which is chronic kidney disease of unknown etiology, which is an emerging entity. The outline of the talk will be introduction, CKD-U prevalence, and hotspots of CKD in the world. And I'll describe about pathophysiology, risk factors, and case definitions available for CKD-U, clinical features, and regional or endemic nephropathies like Mesoamerican, Sri Lankan, Udanam, and Tondai-Mandalam nephropathy. And lastly, I'll tell about the prevention as well as management. So coming to the introduction, globally, the prevalence of the CKD is almost doubled in the last 2 decades. Disproportionately, it is high in lower and middle income economically developing countries. The primary risk factor for the CKD overall will be diabetes and hypertension. But there is an increased prevalence of CKD of unknown etiology across different geographical areas without known risk factors. So that's why the new term called CKD-U has come up, and it is the third most common cause of CKD prevalence in India. So this is one of the Indian CKD study where they diagnosed CKD of unknown etiology is the third most common cause, and the prevalence is around 20%. And the most common cause is diabetic kidney disease, and the prevalence is around 25%. So these are all the few CKD hotspots in the world. Mainly, we should know about Mesoamerican nephropathy, Sri Lankan nephropathy, and Udanam nephropathy. And there are few more nephropathies are there: aristolochic acid nephropathy or Balkan nephropathy, and Ita disease, otherwise called as ouch nephropathy, caused by cadmium exposure. So again, this image shows few hotspots of kidney failure: the Mexico and Central America, which is called Mesoamerican nephropathy, and a few from Sri Lanka, that is Sri Lankan nephropathy, and India, Udanam nephropathy from Andhra Pradesh. So this is the CKD hotspots in India. They have described the heat wave stress. Heat stress is the main pathophysiological factor that is causing the CKD-U. They have mentioned heat wave is usually defined as a sustained elevation of temperature more than 40 degrees Celsius or more than 5 to 6 degrees Celsius from the normal temperature of the surrounding region. The affected areas are mainly Udanam from Andhra Pradesh and Odisha, Akola district of Maharashtra, and certain districts of Goa. And recently, CKD-U has been proposed in Tamil Nadu from the around Puducherry, that is called Tondai-Mandalam nephropathy. So coming to the pathophysiology, the single most important factor will be recurrent heat stress. So those who are working in sunny conditions like farmers, they will prone to recurrent heat stress. So they will be developing chronic dehydration. So that leads to an increased plasma osmolality that triggers the rise in ADH level and activation of polyol pathway. So that polyol pathway activation leads to increase in the fructokinase activity and uric acid level that leads to crystalluria and formation of reactive oxygen species that finally causes acute tubular injury, and slowly the patient will develop tubulointerstitial fibrosis. So this is the another picture that depicts the pathophysiology. Low grade rhabdomyolysis, those will be the contributing factor, but the single most important thing will be the heat stress that leads to the repeated episode of dehydration, activation of fructokinase, and vasopressin mediated acute tubular injury followed by fibrosis. So there will be absence of known risk factors in CKDU. In CKDU, there will be absence of known risk factors like diabetes and hypertension. Mostly men are affected and from the tropical agricultural communities. So there will be absence of traditional risk factors, but presence of non-traditional risk factors. The possible etiology studied were pesticides, heavy metal exposure, infections like leptospira, NSAIDs use, heat and dehydration, and some genetic factors. So this is another image telling about the etiological factors, environmental exposures like pesticides, infections like leptospira, and occupational exposures, and genetic factors. Genetic factors we'll see next. So coming to the genetic factors in Sri Lankan nephropathy, there was SLC 13A3 single nucleotide polymorphism has been reported with odds ratio of 2.1. And another important thing is maternal undernutrition. So mother who is having preeclampsia, eclampsia, giving birth to baby with small gestational age or preterm delivery, especially the weight less than 2 kg, there will be a reduced nephron number. The baby by birth itself, they are prone to CKD. Once they are going into the adulthood population, when they exposed to this heat stress and all, they are more prone to develop CKD. So coming to the case definition, CKD of unknown etiology refers to the chronic kidney disease in the absence of diabetes, long-standing hypertension, glomerular nephritis, obstructive uropathy, or any other apparent causes. So basically, CKD is otherwise called as endemic nephropathy or a regional nephropathy that will sharing the common features like patient in low to middle income countries with tropical climates, predominantly rural agricultural community, male predilection, absence of significant proteinuria, that is proteinuria more than 2 gram, and hypertension for more than 5 years, chronic interstitial nephritis on renal biopsy. So case definition has been split into 3: suspect case, probable case, and confirmed case. Suspect case, the essential criteria will be EGFR will be less than 60 ml per minute by CKD EPI formula and or urine protein 1+ or more on urine dipstick. The exclusion criteria will be history of diabetes mellitus, any history of OHA intake or newly detected DM by random blood glucose more than 200, and known cause of CKD like nephrolithiasis, polycystic kidney disease, or chronic glomerular nephritis, and congenital kidney disease. So probable case will be having the same essential and exclusion criteria as suspect case, but we have to call the patient after 3 months and confirm whether still they are having the essential criteria and exclusion criteria. So confirmed case, the essential criteria will be the same, plus ultrasound showing small kidneys or ultrasound kidneys are normal size. We have to plan for a renal biopsy that will show chronic interstitial nephritis without any immune deposits. So a confirmed case will be having the exclusion criteria like we have to rule out the diabetes. And coming to the BP, a patient in CKD stage 1 and stage 2, a BP should not be more than 140. And patient in CKD stage or more, BP should not be more than 160/100. And patient should not require more than 3 antihypertensive for the BP control. So if any of these present, we have to exclude the patient from the diagnosis of CKDU. And CKD caused by CKD documented by ultrasound showing some obstruction, stones, and tests like vasculitis workup ANCA positive or ANA positive should be excluded. And the proteinuria should be tubular range, that is less than 2 gram. It should not be more than 2 gram per gram. And there should not be any microscopic hematuria, that is RBC 5 or more in the high power field. So this is one paper from Anupama et al. They have defined the Indian CKDU definition. This is all same what I have discussed just now. The only thing is that exclusion criteria mainly they mentioned is proteinuria should not be more than 2 gram per gram. And clinical feature wise, there will be association with dyslipidemia in the form of hypokalemia with or without hyperuricemia. So coming to the clinical features, patient affected age group will be 20 to 50, or recently some 50 to 70 age was reported. Male were predominantly affected. Agricultural community, EGFR is usually less than 60. It is a tubular interstitial kidney disease. There will be no diabetes, hypertension, glomerular disease. Patient presents with a no or low grade tubular proteinuria, arthralgia, and muscle cramps. And the endemic areas, it will get in endemic areas, there will be predominant cases. So basically, CKDU is a tubular interstitial disease. Patient used to present with progressive kidney failure, like asymptomatic rise in creatinine, and urinary finding will be tubular proteinuria, that is proteinuria less than 2 gram, and there will be increased loss of sodium and uric acid in the urine. There will be no glucosuria like renal tubular acidosis, and blood abnormalities. Patient will be having hyponatremia and hypokalemia and hyperuricemia. So when we do a biopsy, the morphological finding will be interstitial fibrosis, tubular atrophy, and because of the interstitial fibrosis and tubular atrophy, there will be compensated secondary FSGS in the form of glomerular enlargement. One important thing is there will be no immune complex at all. So next we'll see about the named endemic nephropathy. The first one is the Mesoamerican nephropathy, which is a prototype of CKDU. So it is a CKDU epidemic in Central America, reported in 2002. First cross-sectional report revealed increased prevalence of CKDU in the Mesoamerican population in Nicaragua in 2010. And Mesoamerican nephropathy was suggested by the World Congress Nephrology in 2011. And first detailed clinical and pathological characterization was done in 2013. The case definition was formed in 2016, but still the etiological and risk factors are not clear. So these are all the characteristics of the Mesoamerican nephropathy. So they took a population where there is no evidence of common causes of CKD. There is absence of diabetes, no hypertension, or hypertension is there, it is only normal or only slightly high. That means within 2 antihypertensives, BP will be controlled. Minimal evidence of GN, there will be no RBC cast, urinary proteinuria less than 2 gram. And ultrasound showed no obstruction or polycystic kidney disease. Clinical presentation wise, most of the time it is asymptomatic rise in creatinine, minimal albuminuria, frequent hyperuricemia, and low potassium level, and biopsy showing chronic tubular interstitial disease with glomerulosclerosis in the late stages. So coming to the diagnosis and management of the Mesoamerican nephropathy, in the CKD stage 1 to 2, first we have to exclude those who are having diabetes, uncontrolled blood pressure, nephrotic proteinuria, urine showing RBC cast, ultrasound showing some obstruction or polycystic kidney disease. And this study, they have removed the patients with age more than 65, as well as creatinine 1.2 to 2. This will lead to the usual cause of CKD. After excluding all this population, what they have studied is age group 15 to 60 with a history of heat exposure and workers spending a lot of time outside. So they will be having proteinuria more than 1 gram, BP normal or slightly high, history of dysuria, hyperuricemia, and hypokalemia. So likely they name them as Mesoamerican nephropathy. And treatment wise, what is the main management is well hydration, avoid extreme heat exposure, avoid sugary beverages, and avoid NSAIDs, and empirical treatment like ARB and SGLT2 inhibitors. So who gets Mesoamerican nephropathy? Age group of 18 to 60, men is more commonly affected, 2:1 ratio. The clinical characteristics typically rise in serum creatinine without heavy proteinuria. Other supportive measures are repeated episodes of unexplained AKI, sterile pyuria, hypokalemia, hyperuricemia, and lack of high blood pressure during diagnosis. When you plan biopsy, biopsy will show tubulointerstitial nephritis. So this is the first report of CKDU from Mesoamerican population in the El Salvador hospital. There they found out that known risk factors is only 33%. The unknown risk factors were around 67%. So they also studied about the decline in the renal function. Usually patient will be having stable EGFR around 80%. 10% of patients showed decrease in the GFR like 3.8 ml per minute per year, and around 10% of people and showed a rapid decline in the form of 18 ml per minute per hour per year was noted. So few people had repeated episodes of AKI, had a RPRF presentation also. So this is another paper which studied about the potential risk factor, that non-traditional risk factors were heat stress, pesticide exposure, and sugarcane chewing. So that's all about Mesoamerican nephropathy. The second variant will be Sri Lankan nephropathy. So in Sri Lanka, CKDU first manifested in the year 1990, and the patients are usually confined to North Central Province, which belongs to the dry zone of the country. Since 1992, Sri Lanka reported the highest CKDU incidence in the South Asian region. Almost 1.8 lakh people were affected. The hydrogeochemistry of groundwater with focus on Sri Lankan nephropathy study showed high fluoride content, ionicity, and hardness of the water. So these are all the certain factors that is associated with the Sri Lankan nephropathy. The important one will be the ground contamination with the fluoride, and biological factors like cyanotoxin, and sociological factors, immunity related, infectious disease like leptospira, dehydration, snake bites, and malnutrition. Behavioral factors like drinking well water, drinking illegal alcohol, cigarette smoking, and excessive tea drinking, especially the black tea as high fluoride content that was proposed by that article. So Sri Lankan nephropathy, this is a genetic consideration. They have done a study where they found out SLC13A13 single nucleotide polymorphism were identified with the odds ratio of 2.1. So coming to Udanam nephropathy, this is the nephropathy from South India. Subtropical low altitude terrain known for the coconut and cashew plantation in Srikakulam, Andhra Pradesh. By 2015, an estimated 35,000 people are diagnosed with CKD. The nomenclature Udanam nephropathy adapted at the 2013 World Congress of Nephrology. Then the similar reports later came from the other parts of the world like Odisha, Akola district of Maharashtra, and certain districts of Goa, as well as from Tamil Nadu. So the main suspected causes are chronic exposure of environmental contaminants through drinking water, food, or air, mainly the groundwater with high levels of silica. So Udanam nephropathy, they've included 67 villages and studied around 2,400 people. In that, 21% found to have CKD. In that, 10.2% has a EGFR less than 60. So that is compared with the people having EGFR of more than 60. The subjects with EGFR less than 60 are phenotypically distinct. Like they are mostly farmers with low BMI, uneducated, hypertension, or family history of hypertension, and they are tobacco users and having some heart disease also. So this is one of the tabular column that compare the endemic nephropathies. So region-wise, Mesoamerican nephropathy is from Central America, from Mexico to Panama. Sri Lankan nephropathy seen in the northern central province, and Udanam nephropathy seen in the Andhra Pradesh. Demographically, age group will be 20 to 60. Affected population, sugarcane workers predominantly in the Mesoamerican nephropathy, and rice farmers in Sri Lankan nephropathy, and cashew and coconut farmers in the Udanam nephropathy. The single most proposed pathophysiology will be the heat exposure. Other findings, there will be high fluoride content in the drinking water proposed in Sri Lankan nephropathy, and high silica content in the groundwater proposed in the Udanam nephropathy. So clinical findings wise, there was no report of AAN in Udanam nephropathy, but few cases of acute interstitial nephritis has been proposed in Mesoamerican nephropathy and Sri Lankan nephropathy. They responded to steroid also. In the chronic phase, all the patients will be having tubulointerstitial fibrosis as well as glomerular sclerosis and renal biopsy. So the next one is Tondai Mandalam nephropathy. So this is the recent paper published from JIPMER at 2020, where they found that in Tamil Nadu, there are 6 districts, mainly Viluppuram, Kadalur, Ariyalur, Kanjipuram, Thiruvannamalai, and Puducherry. So this is a population where there is increased incidence of CKDU. So they have studied almost around 2,400 patients. Most of them are CKD5, And in that, CKD-U is the single most main etiology, around 51%. In that, Viluppuram is a single district that contributes around 20% of the cases. So any patients, if you are getting from this surrounding, you just think about CKD-U when you are picking up the patient and educate them about that this disease is going on in the particular endemic area, so that they can come for yearly screening, and then we can suggest about CKD prevention also. So what are the renal biopsy findings in CKD-U? Mainly it is a tubular interstitial disease. Most of the times you will see tubular atrophy, interstitial fibrosis, and dysmorphic proximal tubular lysosomes. In glomeruli, there will be secondary FSGS in the form of glomerulomegaly. Advanced stages, focal segmental sclerosis will be seen. Vascular lesions, most of the times mild arteriosclerosis will be seen. So mainly this the management is very limited. Most of the CKD-U we need prevention only. So we have to educate the patient about the incidence of the cases in the particular endemic area. We should tell them adequate hydration. If they are working for 1 hour, they should take rest for 1 hour, and they should take a good amount of hydration, especially clean water without contamination. And they should avoid the triggering factors like NSAIDs use, smoking, and there should be a reduced agrochemical exposure and use of PPE as well. And this kind of patient needs early screening and management. So treatment, we can use angiotensin receptor blockers and SGLT2 inhibitors in those who is having some significant proteinuria. But the only problem is they are more prone to dehydration. When you use ARB, SGLT2 inhibitor in this population, again, they will end up in AKI. So if they are completely avoiding this heat stress and all, we can use ARB and SGLT2 inhibitors with adequate hydration. Most of the times there will be hyperuricemia. Few papers showed if it is more than 9 milligram, we can use allopurinol and febuxostat. Bicarbonate supplementation for metabolic acidosis and correction of dyslipidemia such as hypokalemia, and anemia and CKD management as per the CKD stage. So summary, CKD-U is the third most common cause of CKD in India as per Indian CKD study. So CKD-U is the diagnosis of exclusion, and there will be absence of traditional risk factors like diabetes and hypertension, and there will be a presence of non-traditional risk factors like heat stress, pesticide exposure, etc. Clinically, patient presents as tubular interstitial disease with asymptomatic rise in creatinine, hypokalemia, and anemia. So the case definition criteria should be followed to diagnose the CKD-U. The main pathophysiology is heat stress and dehydration that inducing recurrent AKI. Endemic nephropathy such as Mesoamerican nephropathy, Sri Lankan nephropathy, Udanam nephropathy, and Tondemandam nephropathy are reported. Preventive measures should be explained to the population at risk. Treatment will be mostly supportive care and RRT initiation in the ESRD stage. Thank you.
Thank you, Dr. Gopathiraj. Any questions from the audience?
Compared to out of proportion within 1 year of diagnosis something very advanced CKD. Can we consider one of these causes if they have the other risk factors, although it doesn't fit the definition?
Anytime you are diagnosing diabetes,
straight away
exclusion criteria.
Even if it's completely out of proportion.
Anytime you are diagnosing a diabetes or uncontrolled hypertension using 3 antihypertensives, as I mentioned, no CKD stage 1 and 2 BP more than 140, or CKD stage 3 or more BP more than 160/100 will exclude.
And in terms of management,
the one problem is hypertensive nephropathy will be confused with CKD-U. Like any patient you are labeling as hypertensive nephropathy, at least they should have an hypertension for 5 years, and there should be, or if it is not there, they will be having some uncontrolled hypertension. Okay, most of the patients who are coming in CKD-U will be having hypertension less than 5 years, and it is slightly IBP, usually controlled with a single antihypertensive.
And in terms of management, is there anything different from a normal CKD due to any other cause other than ACE inhibitors?
Basically, CKD-U has a very good correlation like a CAN only. The GFR fall will be less only, like 1 to 2 or 2 to 3 ml per minute. The only thing is this kind of population endemic areas, they don't know that they are having CKD. So they are working, no, they will be getting recurrent AKI. So So initially he'll be in CKD stage 2, but when we go for work daily is getting AK, it will rapidly progress. Only thing is in endemic areas, we are getting any patient, we can ask about anybody is having some problem in the surroundings. So we can conduct a camp like that, and early screening can prevent the further damage.
ACE inhibitor, ARB, any roles for the proteinuria?
AC inhibitors and ARB for a CKD patient with significant proteinuria, ARB can be used for any condition. It's not like specific. In this population, only problem is whenever you are using ARB or SGLT2 inhibitor, make sure patient should not be in dehydration. Adequate hydration, correction of metabolic acidosis. So those things should be done before starting the patient on ARB or SGLT2 inhibitors. In this patient, when you start ARB, again is going for the work. Again, he goes for the dehydration. Then ARB itself can aggravate the problem. So we have to make sure that they will get good hydration, avoid work means we can start ARB.
There are few questions online. Is corticosteroid used in CKD-U treatment?
No, actually, some Mesoamerican nephropathy, they are told like in AN phase we can use steroids. Patient present like AN. Patient is coming from that endemic area, but he is presenting like an acute tubular injury. So that case they responded to steroids. But when you are seeing a patient in CKD stage 3 or stage 4, you are seeing certain significant IFTA more than 40% and all, so steroids will not play a major role.
How is the prognosis of these endemic nephropathy patients, especially Tondemandalam nephropathy? How do they
that
do?
is the publication has come the 2 years back only. The detailed study has to be done. They will report actually. They have find out only that in South India, Tamil Nadu also, there is some endemic areas there, especially Viluppuram, Tiruvannamalai. There are more number of cases are coming up. The best management will be prevention in this case.
So is there any papers on Central India causing CKD-U? Because I think even in previous few lectures, we had some doctors from Prem Jyoti Hospital who said they are seeing a lot of CKD without any reason in that area.
The main one is from Udanam, that is from Srikakulam district of Andhra Pradesh. That is studied in detail. In that also the etiology is not clear. They have proposed like some groundwater contamination, those things and all, but still the etiology is unclear. That is the most reported case study, Udanam nephropathy. And recently studies are coming up from all part of the country. Like as I mentioned in Odisha, they are reporting a lot of CKD-U patients. And especially Maharashtra, on Akola district, they are reporting a lot of patients. In Goa also, there are some districts they have started reporting patients. So in future, we'll get a lot of cases from all over the country.
Any other questions?
Thank you for the presentation. My question is simple. Is there a real reason to separate all these entities from Mesoamerican, Sri Lankan, or in the end, actually, it's the same disease?
No, actually, whenever we see a CKD patient, our mind will go to the common risk factors. They'll be having diabetes. Most of the cases are diabetic nephropathy, and they'll be having risk factors like hypertension. When you evaluate, you can pick up some chronic glomerular GN or some obstruction. Okay, so in this disease, you can't find any etiology. So same kind of pattern of disease has been reported from the various parts of the world. In that, the prototype was Mesoamerican nephropathy. Slowly, same kind of disease was reported in the Sri Lanka and Udanam and all. So it is the pattern of the disease that was reported from certain parts of the world, and then the name was given as CKD-U. So it is a diagnosis of exclusion. So you have to study in detail about the etiologies, and finally only you can make this diagnosis.
There's another question online. Is biopsy needed to rule out other causes before labeling something as an endemic nephropathy?
If kidneys are biopsiable, know that etiology is there, then we can do a biopsy also. That's why we are mentioning the biopsy findings and all. Most of the time, it is an interstitial disease in the form of chronic form mostly. When the kidneys are small, you can straight away label as CKD. Biopsiable kidneys, yes, we can plan biopsy.
Any further questions? Thank you, Dr. Gopathiraj, for that lecture. I hope it will help us also to look more for this etiology in further patients and diagnose them. Thank you.
Thank you.
Please join us for lunch after the presentation, and there'll be post-test link being forwarded. Please fill the same. Thank you.